I'm going to introduce again, just to make sure it's on the record, okay? This session is being recorded, and I'm really pleased to welcome Manny Nijar and Michael Dugan, who are going to be talking about the healthcare sector today and staff passports and enabling physician movement. And this is a very interesting application of the technology. I wanted to let you all know today's session is being recorded, so that means that when it comes to the Q&A portion, I'll be running around with the mic asking you to speak into the mic so we can capture your questions for the purpose of the recording. And with that, I'd like to welcome Manny and Michael, and enjoy your session. Thank you for giving it today.
Let's see. Hello, everyone. Good to be here. We will be talking about digital credentials and physician mobility. You see three logos there, FSMB and Truu, and we'll do a brief introduction here in a second, and also the Maryland Licensing Board, who was our regulatory partner in this project. So we'll go through this. I won't spend a lot of time on this, but introductions, a little bit of background, and then we'll get right to the pilot. The Federation of State Medical Boards is a trade association for medical licensing boards in the United States. We have a variety of services specific to this conference and this work. We also provide identity and credential verification. And then Truu.
Yeah, hi. So I'm Manny Nijar. I'm a co-founder of Truu. I'm a consultant physician in infectious diseases, and Truu came about 6 years ago, and we're a platform to basically provide secure, portable digital passports for the movement of healthcare workers, whether that's internally, internationally, or in the virtual world. And it all started from my own problems faced 6 years ago. And I'll tell you a bit more about it when I talk about the technology.
Great. So a little bit of background. At FSMB, we've been working on digital credentials. I look at my colleague Cindy, about 5 to 7 years. So we've had a bit of an evolution. Last year at Groningen, we presented, I didn't know that transition was like that. If I had known, I would have deleted it. Who put that in there? So we had a project called Provider Bridge. It was our COVID project. We provided a digital passport. In our case, they were digitally signed PDFs, but this was a collaboration. It was funded by HRSA, who funds our healthcare and our controls healthcare in our country, and we collaborated with a number of partners, including our counterpart in nursing, who provided data integration. So this was a...
Can I ask you to speak into the mic? I think you're just moving away from it.
Okay, sorry. Is that better?
So, yes, so that it's...
Okay. Yeah. I thought it was a little early for questions. Maybe I'll do that. So this was... How that might be better. So this was our project. It was a... it wasn't in a wallet, but it was a physician-held credential. They didn't have to have information verified through a third party, which, you know, is a big part of the workflow, and was intended for use on the front lines of COVID. So if people were responding to go treat, and early in the pandemic, physicians were traveling all over the country, physicians and nurses. Unfortunately, by the time we love the architecture. We think it's a valuable system. By the time we had a system implemented, there was less traveling going around because COVID was everywhere. But we did get good results. We had, so that was our form of, if you want to call it a certificate of good standing. This slide shows Dr. Nijar's certificate of good standing from the UK. So it's a similar credential, and we'll get into how we pass that along here. So we'll get into, well, I'll let Dr. Nijar explain the Truu ecosystem.
Thanks, Mike. So, yeah, the ecosystem, it's very important, I think. When I started this project, it was all about the physician, and we talked about it yesterday. I think it's about the end user and their engagement and what we're creating for them, solving our own problem. So my problem started 6 years ago. I was working on some night shifts, and there was an agency doctor who I literally couldn't validate his skills because he was a risk to patients. So I kept getting called away every night for about 3 nights, missing out on my patients. So it was a big patient safety issue that really started the process. And then I just said, is there a digital identity solution? So I learnt about the federated models, centralized models. And at that time, SSI and decentralized identity was starting. So I was really fortunate to meet the pioneers of SSI in 2016. And over the years, I've learned about DIDs, verifiable credentials, different blockchains, the pros, the cons, and hopefully I'll share some of those lessons. So fast forward to 2020, when COVID kicked off. By this time, I'd been working with the National Health Service in England, and Truu had done a discovery, a proof of concept, and a pilot with the General Medical Council and hospitals within the UK. And then we went on to deliver a limited product for COVID. Same problems as Mike faced. I was in London. I was leading clinical and operational delivery of COVID, and I was in one of the hardest hit areas, and we just didn't have enough staff. My co-founder, Henry, who's an orthopedic surgeon on the South Coast, his hospitals were quiet. People were scared, and they were just staff. And we wanted to see how can we get that movement. We also spoke to colleagues actually in America, so James Brogan and Christian Rose, who's an associate professor at Stanford. Christian wanted to move from San Francisco to New York really early on, and he faced a 2 to 3 week delay, and by that time, the wave had gone. So we went through and we just shared our lessons, and we got an academic publication, and it's published in Digital Health, and it's actually talking about, I think this is the time for digital credentials. We don't say what architecture, we don't say what technology, but we say this needs to happen now, because rapid deployment in disaster areas and zones, we need to learn from COVID. So the lessons I'll share for the Truu ecosystem, it's split into 2. So you have a governance and legal layer, and this is adapted from a professor from Professor Lassity, who actually looked at our project with the NHS and did an academic review of it. And from a governance and legal perspective, you have a trust diamond. And so this is more important, I'd say, than the technology. So people were talking yesterday, is it interoperability? Is it open standards? No, it's like legislation and collaboration that you can sign up to. So if you look at, this was in our pilots, this was the trust diamond. So we had 4 organisations, so Blackpool Teaching Hospital, the General Medical Council, the Post Office, and the Disclosure and Barring Service, which is the criminal record check authority in the government. And so basically they were issuers, and what they would all issue was, Blackpool would issue that I've worked at this hospital in this role. The General Medical Council would say I have a license to practice as an infectious diseases physician. The Post Office would do my identity verification stuff, saying I am who I am. And the Disclosure Barring Service says I am allowed to work with adults and children and I have not committed any crimes. And that would be issued to me as the holder. And then the verifiers, on the other hand, was Oxford University hospitals. They would, so if I moved, which I had done, if I'd moved from Blackpool to Oxford, they would verify all that information. So that would take minutes instead of months, as it normally would. And Blackpool verified the other information from GMC and Post Office and Disclosure and Barring Service to onboard me there. So but there's a rule. Who writes the schema? What does the credential look like? Who participates in the ecosystem? And that's very important. And so that's the governing authority, and NHS England set the rules for the pilot, saying these are what all the credentials will look like, this is who we trust in the ecosystem, and the technology kind of enables that. It's not perfect, as I'll talk about, but it's getting there. But to get them all around the table took 5 years of a lot of conversations, and it's the biggest healthcare organisation, and they are pioneering it now, and there is a national policy, and there is going to hopefully be a live delivery starting end of next year. In the dash lines, I've kind of just said, in the pilot use case we've done, in America, you can see the equivalence of potentially what could be the issuers, the holders are the same, the verifiers, and potentially the governing authorities. But that would have to be discussed by the American physicians and boards, and I'm not au fait with that system as much as I am in the UK. So the technology, so SSI has come a long way over the last 6 years. So there's 4 layers, and basically, if the bottom 2 layers are what we call cryptographic trust, and that's the technology. So it starts with the layer which is a utility, which is a decentralized identifier method, which is going through W3C as an open standard, but there's various implementations. Our platform initially was built in Evening, and I think Giles spoke about that yesterday, but we've also integrated Matter, so I know Claire quite well, and we've worked on the project, so I think we're the only platform that has 2 different providers because they point to different utilities. So Sovereign is a network, but Matter also provides to ION and the web. So if you go up to the next stage, it's how do you communicate? So how do you make a connection? So there's something called DIDCOM, which is a private VPN which you can exchange the credentials over, and then you can look down onto the blockchain to see who signed it, what organization. And people say it's tamper-proof, but actually it's tamper verifiable. So you can see if it's been tampered or not. It's not tamper-proof. That's a very important distinction. But it's important to know, because if it has been tampered with, you just disregard it. But if you look at that, Matter use a more pragmatic approach and use OIDC, which is OpenID Connect, which is already existing in the internet to exchange the credentials, whereas Evening use PeerDIDs and Hyperledger Aries. And there will be convergence in this technology. The next layer is actually what we call human trust, because that is where this could fail. Because I could issue you a credential, even if you give me the correct information, and we're never going to get to 100% trust with technology, because there's us as humans, right? But we can get to 90 or 95%, and that's the point we're trying to get to. And they're exchanged, and even with the verifiable credentials, although it's a standard, there's various implementations. So just naming 2, there's a non-creds, which allows for selective disclosure, and then there's BBS Plus, which is a different type of cryptography, and there is convergence on that. But as a company, we de-risked it because we don't know what's going to be adopted, and we want to give people the option, depending on their use case, because it's not always about the technology to drive the solution, it's with the use case and having the flexibility and the architectural flexibility to allow that. And where we really lie is at the top, where we create these applications where we can do stuff. So we have a wallet app where the physician can hold their credentials, and we have an enterprise organization app where organizations like FSMB or Maryland can connect with a physician, issue a credential, or actually verify a credential. So we'll move on to the work we did. So I'll talk about the first one. We did 2 pilots with FSMB. So the first one was me, and we first did the manual process and said, how long would it take for me to move to Maryland, and if I wanted to practice. So initially, I would have to log into the GMC, into the portal. They'd issued me the certificate of good standing, which you saw earlier. I then had to let FSMB know, and they let Maryland know, and then they looked it up, and it took I'd say about a month to 6 weeks for that whole process to actually go through it. So we said, well, we carried out and we set up an ecosystem where we set up three enterprise agents or portals representing, 1, the University of Liverpool, where I got my medical degree from, the General Medical Council, and then Maryland Board of Physicians. And what we showed was I connected to the University of Liverpool, got issued my medical degree. I could share my medical degree then with the General Medical Council, and they can prove who I am, and then they can say, yes, you've met the standard, and they issued my license to practice and my certificate of good standing. And then remotely, beforehand, before flying to America, I could potentially just share this information with Maryland, and then they could look up using technology saying every piece of data is verified and issued by these trusted authorities, and we know it's not been tampered with. And that was a very simple pilot, but a process that took 6 weeks took minutes to do. But obviously this is over a lifetime as you collect them as you go along. And then the second use case, which I'll let Mike talk about.
So the second use case was a similar scenario. However, it was with a U.S. physician going to the Maryland board. So we, as our work for the Federation of State Medical Boards, we work closely with the medical boards on their issuing process. So we were able to work through with them, tell them what to expect, that enterprise application was important in this. But we wanted to do two cases. We wanted to cross international boundaries, but then also show, even though Truu is a UK-based system, a domestic in the US. So another party that was helpful here was the University of Maryland. And we had a physician who went there, and we were able to set them up on the system as well. Okay, so now we'll go through the steps, I believe, with the...
So basically, I think it's very simple, and it does get boring after a while, but there's basically 4 steps between the physician. So this is the physician's wallet, and these are screenshots from my app, which I'm happy to show anyone on my phone later if you want to see it. So basically, the first thing is you connect with an enterprise solution, an organization through their enterprise app over the internet. So that could either be, I could go onto a website and scan a QR code, or that they could send me an email, a link, or a text message, which opens up this. So that's the second layer where we make the secure connection. And over that, I can then receive my credential. So this is my verifiable credential. So this is my certificate of good standing in a verifiable credential, digital native format. So better than a piece of paper, actually, because it's harder to... So I could just print that out and change the name. So this has got a high level of trust, technological trust. So I receive the credential, and then what I do is I connect again with the Maryland Board of Physicians, and then I share that credential. And this is quite important from a GDPR point of view, because we have a consent receipt here. I have got an auditable record that I have said, I want to share this information about me with you. It's not going behind my back, which I know it does happen quite a lot in America about certain physicians, and it does happen in the UK as well, in between hospitals within the National Health Service. And the ICO is clamping down on that. And then finally, I passed all the checks, and I get issued my license to practice, and I can go start practicing in Maryland. I have no intention of moving to the US, by the way, just to let you know. This is very interesting. So Cindy was doing some research about this, and she stumbled upon a UK doctor who actually did want to go and work in America. And he started a job at the beginning of September, and he was going through ECFMG and third-party verifiers of his transcripts. And about 3 weeks later, he requested third party for information, but as you can see, he struggled, and almost a month into it, he was going to fly to the UK just to get that piece of information. But then within a week, and after many phone calls, his own admin time, he managed to get in contact with the dean of the medical school, and they sent it via email. Transcripts. Who knows whether that's very secure. And so it almost took him 6 weeks to do that one process. So this is a doctor, as we know. Healthcare workers, the burden is higher, healthcare needs are greater. This is him out of work for 6 weeks where he could be working. It's important. Plus, if you talk about climate change, he would have flown all the way back. That's a big carbon cost just for that. So I think it's a really important message to understand that third parties do have a role, because they could start issuing verifiable credentials as we get the ecosystem going, right? Because they have this capability, right? They can be part of it. Don't see this as a threat to their business models. That's very important, because actually for the greater good of society, there is other business models to be extended off this once they do that. So I'll hand over to Mike, and he'll just talk about the pilots in the future we're deciding to do in the next few months.
Okay, so we came up with possible scenarios. We were hoping to do as many as possible. Here are just a few that we didn't get to, but we're very optimistic about this work, and we intend to continue and just to try to show the utility of it. And that use case, I think, is a great one of why this is needed. There's licensing board to licensing board in the U.S. We don't have a national license. If you want to work in multiple states or move to another state, you have to go through the process again. And it's the same. And many parts of that, you're kind of starting over. So this would be helpful there. And then, so sort of board to board talking as trusted entities. And then the training programs. But to get a license, your residency, what people most know the training program as is very important. You have to be down the path on your residency program before you can get a license. So we think we can connect residency programs directly to the licensing boards. So we'll have, and we use the anglicized here, the lessons learned. But this was an interesting process. We use the same forms that we normally use, the same schema, and we wanted this to be not just, oh, look, this document, and yeah, I could read it. These were the needed credentials for the board to make a decision. Neither of these test cases are going to end up in a license, but the groundwork has been laid there. So there was a fair amount of work there. But the thing, I think, since we went through that standard process, some of the partners in the UK, that extended version, they're like, nope, we don't use this form, we don't know what this is, we're not going to fill it out, is where that sort of dispute came from, and the constant follow-up. We got over that bridge. Also, part of ours, we started with some DocuSign work, and the University of Liverpool wouldn't use DocuSign. They were not comfortable with DocuSign. So that's part of our automation, and they weren't comfortable with it. They completed the form and sent it, but that was an extra step as well. So there's a lot of work here. These higher ed institutions, I know a lot of people at this conference are on board and ready to go, but there's work and education to get those institutions to adapt these tools. I think the other thing to talk initial setup, now that we're set up, we can repeat it over and over and over again, but it is a technical, there's not just a blanket, oh, we can import any document and go. We had to go field by field and incorporate that into the schema and into the application to get the screens that you saw a bit ago. The other thing I'll point out, the Maryland Licensing Board is the head of the curve. There are 70 licensing boards in the U.S. If we, I think, to find an active partner right now, there's less than a handful that probably would have taken this project on and who were willing to say, I will accept documents directly from the physician and count those as authentic and provide source, either source equivalent or source provided. So that's going to be a hurdle for us. We think that at least we have one, and we can move forward and get more, and hopefully more boards. And Maryland sees the value of this. It's just integrated data. I don't have to go log in. The data just shows up in my system, and because of the way it was set up, I know I can trust it. And that should provide great efficiencies for them. So we continue to, our intent is to continue proof of concept work, and even maybe we can productionalize some of this. We do not have a U.S.-based wallet provider to give a similar example, but we'd be willing to talk to folks. I think, and you might want to talk about global telemedicine, but I think that could be, and there's a lot of talk about refugees here, and that creates, some of those are physicians, but refugee situations create a need for healthcare. I don't know if you want to.
Yeah, no, it's really interesting. In the UK, we're suffering a big shortage of healthcare workers, and we know, I think, trans-border telehealth is going to come on board. So how do you verify these people? If we could provide them with a wallet, they hold the credentials, and actually as an interaction between a patient and a doctor virtually, if you could send over a transcript through a channel and they can verify it, at least you have it. And there's a bit more work we're doing integration with biometrics, so that person that biometric is attached to a credential as it's sent over, because I could give my phone to Mike, couldn't I, and set him up and so that's our next piece of work. We're integrating with an IDV, which is an American company actually, so hopefully that will lead for us to do more work in America. And that's, yeah.
Yeah, I think the rest of these are kind of self-explanatory. We need more adoption of the tools for them to become commonplace. I think, for the acceptance to grow up. So I think we've left a few minutes, Kathleen, for some questions.
Thank you. Sorry, that was. Thank you very much. That was a great presentation. I'm completely intrigued by the application. And so a round of applause for them. Yeah. And I see we have our first question. So Meg, I'll just run up to you here.
Never get out of this chair.
I know, right? I was also getting comfortable.
So have you thought at all about the credential evaluation piece? And I'll give you an example. So we're a credential evaluation agency, and we evaluate all of the credentials for people educated in other countries who want to practice as pharmacists, dentists also, as a matter of fact. And so it's not only the validation of the credential, so that's part of what we do is confirm the authenticity of the credential, but we provide an analysis. What was the admission requirement? What is the length of the program? What is the content of the program? Is it equivalent to a U.S. degree? For example, in pharmacy now, the first professional degree is a doctorate of 6 years. Many other countries still have 4- and 5-year first degrees in pharmacy. And so have you thought at all about professions in which there's this step of credential evaluation?
So yeah, we've thought about that, and I think the slide about the trust diamond that's where that becomes really important in the government. So there is a role for everyone, right, to do that. If you're already existing, we don't want to disrupt people's business. We want to bring everyone on board to allow that, to facilitate that. So potentially sitting at that time where the schemas are designed, do the attributes have to say you've done 4 years, 5 years, 6 years? They can all be agreed, right? And that's what the NHS are doing, and they're bringing people in who do that, because if you've got the expertise and you've already got the relationships, there's no point reinventing that. We're just trying to implement a technology to facilitate that, and it is an important piece. And I would say that first trust diamond is actually more important than any of the technology I've shown to get this going.
Thank you. Any other questions? Okay, I do not. Victoria.
I'd like to ask a stupid question. I like all this, but what happens if you lose your phone?
Yeah, that is a good question. We are doing cloud recovery and backup on that.
Encrypted?
Yeah,
Okay.
yeah. And also paper-based stuff, because actually, like what Claire said yesterday, Matter, if there are doctors who don't have phones somewhere and have paper, you want to be able to link it. And it's about inclusion. And no question is a silly question, by the way.
Well, and on that one, I will add that as we've looked at the folks, that's a part of the Truu solution that we really, I don't know if everyone's progressing there, but for wallets to really take hold, you need that sort of a backup, because you will lose your phone. So.
Thank you very much. Thanks, everyone, for attending this session today, and to Manny and Mike, thank you very much for your presentation. Very interesting initiative.